Your cardiovascular system is doing something different at night than it does during the day. Not in a way you can feel, not in a way that wakes you up most of the time, but in a way that quietly reveals whether the next 5 years of your life will include a stroke or not. That nighttime pattern is happening inside the bodies of millions of adults over the age of 60, and most of them have no idea it is being recorded second by their own physiology. By the time the symptoms become impossible to ignore, by the time the family member finally drags them to the GP, by the time a scan reveals what has been building up in their arteries, the warning had already been showing up at night for years. Stroke is one of the most devastating events that can happen to an adult over 60. It does not give you the kind of warning that a heart attack often gives. It does not always cause pain. It strikes suddenly, leaves lasting damage in a single afternoon, and changes everything from how you walk to how you speak to whether you can stay in your own home. And the problem is that for decades, we've been told to watch out for the daytime symptoms. Sudden weakness, slurred speech, drooping on one side of the face. Watch for those, we were told, and you'll catch a stroke as it happens. Except by the time you are catching a stroke as it happens, the damage has already started. What cardiologists are now confirming through sleep studies, through long-term outcome data, and through what we are seeing in clinical practice is that there is a single symptom occurring at night that predicts stroke risk years before the event itself. And once you understand what it is, you can act on it long before it becomes irreversible. Hi, I'm Dr. Alex. I'm an emergency medicine doctor, and after nearly 10 years working in A&E, I've seen what happens when preventable disease isn't prevented. I've seen what a 65-year-old looks like when they wake up from a stroke and cannot move the right side of their body, and I've seen the families standing in the corridor trying to understand how no one saw this coming. And my goal now is to help people avoid that outcome and live longer, healthier lives. So if you're watching this video, you're probably worried about your blood pressure, your heart, a family history of stroke, or simply about protecting your independence as you age. And I just want to take a few seconds here to make you a promise. I promise to keep creating the most helpful videos I possibly can, grounded in science and the latest research to help you protect your cardiovascular system and avoid the diseases I see in the emergency department every single day. And all I ask in return is that you give this channel a chance and hit the subscribe button. If you get to the end of this video and you didn't think it was worth your time, or you haven't learned something new, then feel free to unsubscribe. No hard feelings. But if you give me your time and your attention, I'll give you everything I've learned from over a decade in medicine. So please help me out. Hit the subscribe button to help this channel reach more people like you. And let's continue with the video. Now, before we name the nighttime symptom in question, we need to understand what is supposed to happen inside your cardiovascular system while you sleep, because once you see what normal looks like, the warning sign becomes obvious. Your body operates on a 24-hour rhythm called the circadian cycle, and your blood pressure follows that rhythm closely. There are 3 things that should be happening at night in a healthy adult. The first is what cardiologists call nocturnal dipping, which is a natural fall in blood pressure of about 10 to 20% during deep sleep. The second is a slowing of the heart rate, driven by the parasympathetic nervous system, which is the calming branch of your autonomic system that takes over once you're asleep. The third is a quiet, steady breathing pattern with stable oxygen levels and minimal disturbance to the heart and brain. When all 3 of these are happening properly, the cardiovascular system gets the recovery time it needs. The arteries relax, the heart rests, the brain receives a steady supply of oxygenated blood, and the whole system is being repaired and reset overnight in preparation for the next day. The problem starts when this nighttime recovery does not happen. When blood pressure stays elevated at night instead of dipping. When the heart rate stays high. When breathing becomes irregular and oxygen levels drop repeatedly without the person ever waking up enough to remember it. Those quiet disturbances are not minor inconveniences. They are repeated stress events on the very vessels that feed your brain, and they leave a measurable mark over time. So the real question isn't whether your blood pressure looks acceptable when measured during the day at your GP appointment. The real question is what is happening to it between 2 and 4 in the morning, because that is where the truest signal of your future stroke risk lives. And here's where the picture gets clearer. The cardiovascular system responds badly to 3 specific nighttime patterns, more than almost anything else. The first is non-dipping or reverse dipping, which is when blood pressure fails to fall at night or actually rises higher than it was during the day. The second is repeated drops in oxygen caused by interrupted breathing, which forces the heart to surge and the arteries to constrict dozens of times an hour. The third is fragmented sleep architecture, which prevents the deep restorative stages where the cardiovascular system normally repairs itself. And research published in journals like Circulation, Hypertension, and the European Heart Journal has shown over the last decade that the strongest single predictor of future stroke in adults over 60 is not their daytime blood pressure reading. It is what their body is doing at night. Think of your cardiovascular system like a busy highway during the day. Traffic flows. Lanes are busy. Pressure is normal. At night, that highway is supposed to empty out. The road surface gets repaired. The traffic lights are recalibrated. The whole system gets ready for the next morning. But if the highway never empties, if the traffic stays heavy through the night, the road surface never gets repaired, and over years it slowly cracks and gives way. That's exactly what is happening inside the arteries of adults whose nighttime cardiovascular rhythm is broken, and the eventual cracking shows up as a stroke. Here is what makes the nighttime signal so powerful as a predictor. During the day, your body has enormous compensatory capacity. Your heart speeds up when you stand. Your arteries constrict and relax as needed. Your nervous system responds to stress, to caffeine, to emotion, to movement. The system has so many active inputs that a single problem can be hidden by all the others. At night, all of that compensation switches off. The system is laid bare. Whatever is wrong with the cardiovascular regulation, whatever is wrong with the airway, whatever is wrong with the autonomic balance becomes visible because there is nothing else moving to mask it. That is exactly why cardiologists are now paying so much attention to overnight data. It is the cleanest signal we have. It is the place where the body cannot pretend. And just really quickly, if you're getting some value from this video so far, then please consider subscribing to the channel. It really helps these videos reach more people like you. Anyway, let's continue. So let me name this explicitly, because up to this point we've been building the case, and I want to make sure this lands in practical terms. The single symptom at night that cardiologists are now confirming as the strongest predictor of stroke in adults over 60 is loud, repeated snoring combined with brief pauses in breathing, which together form the early presentation of a condition called obstructive sleep apnea. That is the mechanism that is driving stroke risk in a huge number of adults who would otherwise be considered healthy and well-controlled on paper. And I want to be very clear about what I mean, because this is not about the occasional quiet snore that everyone produces from time to time, especially after a glass of wine or when they have a cold. This is about the persistent, heavy, disruptive snoring that the partner in the next room can hear through a closed door, often accompanied by gasps, chokes, or strange silences that last several seconds before the person suddenly snorts back to life. Those silences are not peaceful pauses. They are repeated episodes of airway collapse, during which oxygen drops, carbon dioxide rises, and the cardiovascular system is forced into emergency mode dozens or even hundreds of times per night. This shows up in a few different ways, and each one is worth understanding because most people genuinely don't realize what is happening to them while they sleep. The most obvious version is the partner who complains every morning about the noise, who has moved into the spare room, who reports seeing the sleeper stop breathing and then jerk awake. This is not a relationship problem, it is a medical signal. The less obvious version is the person who sleeps in the same bed alone, who has no one to witness their nights, but who wakes up feeling exhausted despite 7 or 8 hours in bed. They believe they slept through the night. In reality, they were waking up dozens of times a minute, just enough to restart their breathing, but never enough to remember it in the morning. Then there is the category of subtle daytime signs that look like ordinary tiredness or aging, falling asleep in the armchair after lunch, struggling to stay awake during the evening news, drinking more coffee than ever to get through the afternoon, morning headaches, a dry mouth on waking. None of these on its own would prompt a doctor's appointment, but together, in combination with nighttime snoring or witnessed apnea, they reflect the same underlying problem. And finally, there is the most dangerous category, which is the person who has been told by their partner for years that they snore loudly, who has heard it described as funny or annoying or simply a fact of getting older, and who has never once asked whether it might actually be a warning sign. It almost always is, and I want to say this clearly because it matters. If you or someone you love is showing these signs, it is not anyone's fault. It does not happen because of weakness or because of poor self-discipline or because someone failed to take care of themselves. It happens because the way modern medicine screens for stroke risk has focused almost exclusively on daytime blood pressure, cholesterol numbers, and visible heart symptoms, while overlooking the single most important window of cardiovascular activity, which is the 8 hours you spend asleep. You did not miss anything. The screening system did. The reassurance you received at your last checkup wasn't a clean bill of cardiovascular health. It was a clean result on tests that don't measure the function that fails first overnight. And the consequence of that gap is a generation of adults whose nighttime breathing has been quietly priming them for a stroke, while their daytime numbers continue to look acceptable. The combination of disrupted breathing, repeated oxygen drops, and non-dipping blood pressure creates exactly the conditions in which arteries inflame, plaques destabilize, and brain blood vessels eventually fail. The stroke does not happen overnight. It happens after years of nights. So what's the solution? Well, I want to frame this very carefully because I'm not advocating for panic. I'm not suggesting that every snore means a stroke is coming, and I'm certainly not suggesting that any single intervention will guarantee protection. What I am saying is that if you want to give yourself the best possible chance of avoiding a stroke after 60, then you need to take nighttime breathing seriously as both a warning system and a target for treatment. And that requires a small set of practical changes that protect the cardiovascular system overnight. The first change is the most important one, and that's getting a proper assessment for sleep apnea if any of the warning signs apply to you or to someone you love. The assessment is straightforward, widely available, and often can be done at home using a small overnight monitor. Research published in the European Heart Journal has shown that treating moderate to severe sleep apnea can reduce stroke risk significantly, particularly in adults over 60. In practical terms, what that means is that addressing the breathing problem at night protects your brain during the day, and the earlier in the disease process the treatment starts, the greater the protection. The second change is protecting your nighttime blood pressure pattern, because non-dipping blood pressure is one of the strongest independent predictors of stroke we have. Anything that keeps your sympathetic nervous system activated overnight, including alcohol close to bedtime, late heavy meals, ongoing emotional stress, untreated reflux, and stimulating screen use late in the evening, all interfere with the natural fall in blood pressure that should be happening between 2 and 4 in the morning. Calming the hours before sleep is not a wellness trend. It is direct cardiovascular medicine. Remember what I said about the highway needing to empty at night? This is how you allow that to happen. The third change is body position and weight around the neck and abdomen, both of which influence whether the airway stays open during sleep. Even modest weight loss has been shown to reduce the severity of sleep apnea, and sleeping on your side rather than on your back keeps the soft tissues of the throat from collapsing into the airway. These are not glamorous changes, but the research published in Hypertension has shown them to produce measurable improvements in nighttime blood pressure and breathing patterns, often within weeks rather than months. The fourth change is alcohol. This one surprises people, but the evidence is now very strong. Alcohol relaxes the muscles that hold your airway open, depresses the brain's drive to breathe regularly, and disrupts the architecture of deep sleep. Even a couple of drinks in the evening can convert a mild snorer into someone with full obstructive episodes overnight. If you snore, if you have been told you stop breathing in your sleep, or if you wake up feeling unrested, the single most powerful evening intervention you can make is to stop drinking within 4 hours of bedtime, and ideally to reduce overall intake substantially. The fifth change is treating the upstream causes that often sit behind apnea, which include nasal congestion, allergies, reflux, and undiagnosed thyroid problems. Many adults assume their breathing problems at night are a structural fact of life. In reality, persistent nasal blockage, untreated reflux, and metabolic conditions often turn manageable airway anatomy into a clinical problem. Addressing these upstream issues, often with the help of a GP or specialist, can substantially reduce nighttime breathing disruption without anyone needing aggressive intervention. The sixth change is getting a 24-hour ambulatory blood pressure monitor, particularly if you have ever been told your daytime blood pressure is borderline or controlled, but you still feel unwell. This is a small device that takes a reading every 20 or 30 minutes for a full day and night, and it is the only reliable way to find out whether your blood pressure is genuinely falling at night the way it should. Research published in the European Heart Journal has shown that nighttime blood pressure is a stronger predictor of cardiovascular events than daytime blood pressure, and yet most adults have never had a nighttime reading taken in their entire lives. Asking for this test is one of the most useful things you can do for your cardiovascular future after 60. And I want to be very clear that I'm not suggesting anyone stop taking their blood pressure medication or any other prescribed treatment without talking to their doctor. It's not safe, and it's not something I would ever recommend. But what I am saying is that medication and lifestyle are not mutually exclusive. They work better together. And if you've been on blood pressure medication for a while and your daytime numbers look fine, but you continue to feel exhausted, snore heavily, or have a partner who has noticed pauses in your breathing, then it's worth asking your doctor specifically about a sleep study and a 24-hour blood pressure monitor. Let me bring this back to what I see clinically, because I think it really helps to ground the physiology in actual patient outcomes. I've had patients come into the emergency department with their first stroke at 62, at 65, at 68, and almost without exception, when you sit down with the family afterwards, somebody mentions the snoring. The partner says he has snored like that for years. The daughter says they all used to joke about it at family holidays. The brother-in-law says he could hear it through the wall of the next hotel room. Nobody ever connected it to stroke risk because nobody told them to. And underneath that pattern, the daytime blood pressure had often been managed reasonably well. The cholesterol was acceptable. The patient looked on paper like a manageable case. The thing that finally tipped them into a stroke was happening every night, for years, in plain hearing of everyone in the house. What's remarkable is the difference in outcomes between patients who get apnea diagnosed and treated before any cardiovascular event versus those who get diagnosed in the recovery ward afterwards. Patients treated proactively, often with positive airway pressure therapy, with weight management, with positional changes and alcohol reduction, often see their nighttime blood pressure normalize within weeks. Their daytime energy returns, their headaches resolve, and their long-term stroke risk drops measurably. That is not a guarantee. We don't have guarantees in medicine, but it is a meaningful reduction in risk that can be the difference between an independent life into the 80s and a sudden life-altering event at 65. So where does this leave us? Stroke isn't just a single catastrophic event that strikes out of nowhere. It is the visible endpoint of a slow process happening inside the cardiovascular system, and one of the loudest, most reliable early warnings of that process is happening every single night in adults who have stopped breathing properly while they sleep. What's less well appreciated is that the mechanisms driving sleep apnea, the airway collapse, the oxygen drops, the surges in blood pressure, the inflammation, are the same mechanisms that drive heart attacks, atrial fibrillation, vascular dementia, and the slow loss of cognitive sharpness in late life. These are not separate conditions that happen to occur together by coincidence. They are different manifestations of the same underlying nighttime cardiovascular stress. When you address the root cause, you are not just reducing your risk of stroke. You are protecting your heart, your brain, your blood pressure, and your ability to remain independent as you age. That's the real prize here. So, let me bring this full circle. Stroke after 60 doesn't appear out of nowhere. It announces itself, often for years, through the way someone breathes at night. If you snore loudly, if your partner has seen you stop breathing, if you wake up tired no matter how long you slept, if you live alone but you feel unrested and unfocused, take it seriously. Get a sleep assessment. Get a 24-hour blood pressure monitor. Address the alcohol, the position, the weight, the upstream causes. And if these signs are showing up in someone you love, do not let the snoring be the family joke any longer. It is the warning the body has been giving for years. And so after all of that, if you found this video useful, then please subscribe to the channel and let's help as many people as possible.